For over 10 years of clinical work in critical care, Dr. Kwizera has frequently confronted death of patients suffering with acute respiratory failure. Throughout the day, he reviews patients, especially those in intensive care units, multiple times, ensuring to stabilize them. As a senior intensivist and anesthesiologist at Malago National Referral Hospital, he leads a multidisciplinary team of medical workers to make decisions that impact patients' recovery. With the ever-revolving face of medical care practice, Dr. Kwizera has been inspired to participate in and lead clinical inquiry in critical care medicine.
I decided to go into acute respiratory failure because, as you know, a lot of emphasis is given to childhood pneumonias, but and very little is given to adults. And we know, other than if it's tuberculosis or HIV-related pneumonia, those who are left out. The care is not even planned for. If you look at clinical guidelines across the world, the care of a patient with respiratory failure just doesn't sit well. So I decided to study acute respiratory failure for my PhD to tell Africa's story.
When COVID-19 hit Uganda, it overwhelmed hospital emergency rooms and ICUs with patients. Uganda desperately sought the expertise of anesthesiology intensivists like Kwizera to secure the airways of critically ill patients and provide respiratory support with mechanical ventilation. Many patients were already suffering grave COVID-19 complications such as septic shock, acute kidney injury, and acute respiratory distress syndrome that required ICU admission for better management.
My PhD work was respiratory failure, and COVID causes respiratory failure, so I became a member of the Scientific Advisory Committee, Ministry of Health, and my focus was basically the research and clinical management. I also became a member of the Case Management Committee, coming up with adopting the guidelines that I had helped write in Geneva. It has been a humbling journey. We worked with the ministry to design specifications, equipment, as well as the building designs for the ICUs that would be set up at the regional referral hospitals. So when the COVID wave hit Uganda, we were fairly ready in some respects.
Although creative initiatives were undertaken by Uganda's government to convert operating rooms and sports stadium into ICUs, a major challenge of inadequate mechanical ventilators to provide respiratory support to patients with severe COVID-19 was rampant. To be able to match the high ICU demand and stave off ventilator shortage, Dr. Kwizera secured 25 cost-effective high-flow nasal cannulas and 250 CPAP masks from New Zealand-based manufacturer Fisher & Paykel.
When we were setting up these ICUs, we bought 200 ICU beds. Before that, we only had 30 functional government ICU beds. What we are now trying to do is say, okay, in the meantime, what can we do? We know the burden of respiratory failure. What else can we do? So this is where the other aspect of my work comes in. If you have respiratory failure, the go-to had been that you would need a mechanical ventilator. That costs about $50,000, and you need to be a specialist doctor and 2 years of added training to use it. On top of that, it has to be in a dedicated place, needs electricity, needs medical gases, and so on, maintenance. If I had 100 patients, all come with respiratory failure, can't I just maybe say, reduce the need for mechanical ventilation by 50%? So this is where this device comes in. This is just a high-flow oxygen machine. It's about maybe let's say 10, in terms of total cost, about 10% the price of the ventilator. This device can be used, does not need an extremely highly skilled person. This person just needs to know how to. The training they will take with just 1 week training to use it, and it can be applied outside the ICU environment.
With the curiosity of a child, Dr. Kwizera now seeks to compare the effectiveness of these two devices in reducing the need for mechanical ventilation. This year, he won a Wellcome Trust grant to conduct a clinical trial in 15 Ugandan hospitals to find answers to his research question.
Fisher & Paykel also donated 25 of these for the trial because they are also interested. This should have happened earlier, but because of the COVID pandemic, they didn't have any to spare. We also got a donation of about 250 CPAP devices. So at the end of the trial, we are donating all this to the sites that are participating in the study. So Mulago Hospital ICU, as you can see, we've given them 2, and if the recruitment rate is good, we can even give them more. So the 15 hospitals will share the 25 devices. And our hope is that becomes the new normal in caring for patients with acute respiratory failure as we figure out the longer term issues.
Wholly, Dr. Kwizera's clinical and research career demonstrate that immense opportunities for innovation in critical care abound. What remains is to exploit available knowledge to promote innovation studies that enable faster application in clinical practice.